Hi, I am directing this video to my patient and to every patient who is willing to undergo plastic surgery or cosmetic surgery. And what I will discuss here is the perioperative pain management before, during, and after surgery, and how I do it differently and why. First, if we want to talk about pain management, we want to understand how pain happens. If we want to analyze how the signal starts in the tissue. Um, if you see this diagram, it starts with nociceptive signals in the tissues, like injuries, burns, cut. All those signals will travel through the nerves into the spinal cord, and they will travel into the brain. We do not call those signals pain till the brain decide it is pain. And this is where I need your attention. The brain decides if those signals are painful or not, even if they are or they should be painful. For example, uh, in the battlefield back in the days, or even nowadays, if you get shot like by a gun in the battlefield, or get stabbed by a knife in the battlefields, the brain is less likely to interpret that as severe pain, because the brain knows that you need to survive and you need to run or fight back. So even if those signals are very painful, the brain will kind of shut them down temporarily, and you will have the pain later. And this happens like even during sport games, when people dislocate or spray their knees, they will not have the pain till after the game, because the brain decides it's not the time to have pain right now. Even President Reagan was actually shot and didn't know he was shot till after his speech. And considering that, we target the pain signals in different locations. In the local tissue, we target them by the local anesthesia, which is the lidocaine, which I use extensively in my practice. So less pain signals will travel to the brain if we use local sedation. We talked about that before. So if you use a lot of local anesthesia, there are much less pain signals will travel to the brain initially. The other target in the tissue is also the NSAID, which is the non-steroidal anti-inflammatory, like the ibuprofen, the naproxen, the meloxicam, and diclofenac. Those are anti-inflammatory, and they decrease the amount of uh, uh, noxious stimulant into the nerves, and decreases inflammation. They are good to a certain degree because we heal by inflammation. So we want to actually give those medications to a certain extent without inhibiting the inflammation, but by kind of shaping that inflammation, that it will not be out of control. And in my opinion, sometimes if you're able to run without them, that's actually a good idea, because if you heal without an active inflammation, you'll heal kind of slower. Um, so how do we target pain? We said in the tissues, we target them here around the tissue with local anesthetic and with NSAID. Around the nerves here, we target them by the opiates, which is the hydrocodone, oxycontin, morphine, and with something called alpha-2 agonist, which is the gabapentin and the pregabalin. And also we block them in the brain itself by doing general anesthesia, or by doing also alpha-2 agonist, and also by the opiates. So the opiates work on the brain mainly and the spinal cord, and they're not good for many reasons. 6% of the people who receive opiate after surgery, they become addicts. And this is a scary number. Can you imagine if you have 100 patients and you give them opiates? 6% have a great chance of becoming an opiate addicts. Not dysfunctional, but they will become more dependent on those opiates. So that's why now we have the gabapentin, which is the medication that, in my opinion, is also changing the equation. So why do I use gabapentin? So the gabapentin is an agent that target the alpha-2 receptors here in the synapse, in the spinal cord, which is around the nerves here, and also it attacks the receptors in the brain. So it kind of blocks those channels from producing a signal that travel to the brain, and also ask the brain with those receptors to send inhibitory factors to block any perception of pain. And also it decreases the anxiety in a way, and also help the patient sleep better. So I use gabapentin even before surgery. And the reason I do this, because there is plenty of research that shows that even a single dose of gabapentin before surgery can decrease the pain after surgery and can decrease the dependence on opiates, and also decrease the overall pain. It also decreases the anxiety and allow early ambulation and early recovery, like in this study. And also a single dose, like in this study, decreases the postoperative pain in acute surgery. So bottom line, I use gabapentin for 2 to 3 doses before surgery. So I ask my patient to start in the afternoon because I expect that it works. So I ask them to take it around 4 to 5, and then one before they sleep, and then one in the morning of surgery. They take it here. And those 3 doses kind of blunt the nerve reactions to pain and allow the local anesthesia to work better. Most importantly, the patients sleep very well that night, so they come to be well rested. And as I told you, the brain has a major factor in deciding how much pain you have. So if you are stressed, if you are sleep deprived, if you're not trusting your surgeon, if you have obsessive compulsive disorder, you will have much more pain than a normal person who come well rested and who had less anxiety. So this gabapentin is the only medication that I give before surgery. And after surgery, I still give it every 8 hours, but also I add into it the opiate and add the anti-inflammatory. So we target the pain in 3 sources of signaling and perception. And that, to summarize, the postoperative and perioperative pain management after plastic surgery and why I do this. I hope you find this video helpful. Thank you.